Welcome to Roadmap to Residency. Hello everyone, I'm Abhi. Welcome to our Club 215 Mass Micro Sessions. We will be running through some questions with you guys to help you on a journey to 250. So a 28-year-old woman, G2P1, presents to the labor and delivery unit in active labor. Upon examination, she is fully dilated and the fetal head is at +1 station. The contractions are strong and occurring at regular intervals. As the woman progresses through the stages of labor, which of the following represents the initial stage of the second stage of labor? Latent phase, descent phase, expulsion phase, crowning phase, or deceleration phase. So the stages of labor are typically divided into the first, second, and third stages. The second stage of labor begins when the cervix is fully dilated and ends with the delivery of the baby. So, the first stage of labor is when the patient starts having true uterine contractions up to the full dilation of cervix. The second stage of labor is when there is full dilation of cervix up to the expulsion of the fetus. And the third stage of labor is from the expulsion of fetus to the expulsion of placenta, and also there is addition of the third stage of labor, also the fourth stage of labor, which is the 1 hour of monitoring period after the expulsion of the placenta. So the expulsion phase is the initial part of the second stage of labor, and during this stage, the woman actively pushes to assist in the delivery of the baby. The fetal head descends through the birth canal and the baby is born. The expulsion phase is characterized by the active maternal effort to push the baby out. So this is the stage of labor and birth in a vaginal delivery. So first of all, the head is floating in the uterine cavity before engagement. And when the head becomes engaged, then the head is fixed, okay? The head is non-ballotable. And there is flexion at the head and there is descent occurring. And after that, there is again further descent with internal rotation of the head. After that, there is complete rotation and there is beginning of the extension of the head as the baby comes out of the vaginal canal. Then, when the baby gets delivered throughout the vaginal canal, there is the complete extension. So the baby delivers by complete extension. Now, when the baby delivers by complete extension, then again there is the restitution, that is the external rotation of the head. Now, after that, there is the delivery of the anterior shoulder, and then there is the delivery of the posterior shoulder. And once the anterior and posterior shoulders are delivered, then the whole of the body just comes out. So cervical dilatation by vaginal examination. So whenever you are in the labor ward, then you are asked to check the dilation of the female. So the fully dilated cervix is 10 centimeter. So, but you do not use a measuring scale to measure the dilation, but rather you use your fingers to measure the dilation. So when you can insert one finger in the cervix, then it means that the cervix is 2 centimeter dilated. When you can insert two fingers, it means it is 3.5 centimeter dilated. When you can insert three fingers, it means that it is 5.5 centimeter dilated. Or when you can insert four fingers, it means that it is 7.5 centimeter dilated. So dilation of the cervix. So the process of cervical effacement and dilatation causes the formation of the forebag of amniotic fluid, which is the leading portion of the amniotic sac and the fluid located in front of the presenting part. As uterine contractions cause pressure on the membranes, the hydrostatic action of the amniotic sac in turn dilates the cervical canal. In the absence of intact membranes, the pressure of the presenting part against the cervix and the lower uterine segment is similarly effective. So, which of the following parameters is primarily measured by the tokodynamometer? A 34-year-old woman, gravida 2 para 1 at 38 weeks of gestation, arrives at the labor and delivery unit with regular contractions. The obstetrician decides to monitor her uterine contractility to assess the progress of labor. The patient is connected to a tokodynamometer for this purpose, and the tokodynamometer provides continuous monitoring of uterine contractions. And during contractions, the device measures the frequency, duration, and intensity of the uterine contractions. The obstetrician uses this information to evaluate the progress of labor and to assess the effectiveness of the contractions in promoting cervical dilation and effacement. Now, which of the following parameter is primarily measured by the tokodynamometer? Fetal heart rate, uterine pressure, cervical dilation, fetal position, or amniotic fluid volume. So even though the question is a long question, but it is a very simple, straightforward question. So The torque dynamometer primarily measures the uterine contractions by monitoring the uterine pressure. Now, it provides the information on the frequency, duration, and intensity of contractions. Now, this data helps healthcare providers assess the progress of labor, determine the effectiveness of contractions, and promoting cervical dilation and effacement, and identify any abnormalities in the uterine activity. So about uterine contractility, our knowledge is still insufficient, but the uterine contractility is regulated by calcium, progesterone, oxytocin, and prostaglandins. So that's why nifedipine is used as a first-line medication for the treatment of premature contractions. Progesterone, so IM injections weekly in the cases of previous premature birth. Oxytocin, which leads to the induction of labor, prophylactic administration immediately after the second stage of labor is completed, and is the treatment of the atonic uterus. The prostaglandins like misoprostol and sulprostrol can also be used. So, if there is any deviation of the normal pattern of uterine contractions affecting the course of the labor, is designated as the disorder or abnormal uterine action. So, it can be due to over efficient uterine action, example precipitate labor in absence of obstruction, the excessive contraction and retraction in the presence of obstruction. So inefficient uterine actions, example, hypertonia, or constriction ring. Or you can also say Bandal's ring, or it can be due to cervical dystocia. So here we have one more question. So which of the following term accurately describes the observed phenomenon of the fetal head becoming visible and then retracting inside the birth canal during contractions? Crowning, engagement, descent, fetal station, or breech presentation? So, crowning is the term used to describe the appearance of the fetal head at the vaginal introitus during contractions. It occurs when the widest part of the baby's head is visible as it moves through the birth canal. The head may seem to crown during contractions, but may retract slightly between contractions. So, which of the following best characterizes the milestone in preparation for childbirth? So, 32-year-old prime gravida at 38 weeks of gestation visits the obstetric clinic for a routine prenatal checkup. Upon pelvic examination, the obstetrician notes the successful engagement of fetal head, and the patient experiences increased pelvic pressure and occasional difficulty in breathing. The obstetrician explains that engagement indicates the descent of the widest diameter of the fetal head into the pelvic inlet. Now, which of the following best characterizes this milestone in preparation for childbirth? Fetal head visible at the vaginal introitus, fetal head entering the birth canal, fetal head reaching the pelvic floor, fetal head descending below the ischial spines, or fetal head rotation to align with the maternal pelvis. So, engagement in the context of childbirth refers to the descent of the widest diameter of the fetal head into the maternal pelvic inlet. Now, it indicates that the fetal head has reached or passed the level of the ischial spines within the pelvic inlet, and this descent is a crucial step in the birthing process, preparing the fetus for delivery through the birth canal. So, station and engagement. So, station is the relation of the presenting part to the ischial spine. Now, if the presenting part is at the level of ischial spine, the station is 0, and ultimately if it goes below the ischial spine, it is +1, +2, +3, above the ischial spine, -1, -2, -3. Engagement is the descent of the biparietal diameter through the pelvic rim. So if the head is at the level of ischial spine, the head must be engaged. So it should be assessed by abdominal examination um, immediately before doing a vaginal examination using the rule of fifth to assess engagement. The rule of fifth means the palpable fifth of the fetal head are felt by the abdominal examination to be above the level of symphysis pubis. So 5 means if you are able to rest all the 5 fingers above the fetal head, above the pubic symphysis, then it means that the descent of the fetal head is 5 and ultimately as the number of finger decreases, the 4/5, 3/5, 2/5, 1/5, or 0/5, we can level it in that way. Thank you for watching. Keep studying hard.